Hello, everybody. I'm so grateful to Dr. Park and his staff for the chance to discuss with you some cases, knowledge, and something related to our daily job. My focus up today is related to the global approach to complex cases. I will talk about the story of this girl needing the restoration of this left central incisor, but when we shoot the first picture extraordinarily, we saw that the problem probably was related to all the premaxilla area, and we can see how she displays the black holes and this asymmetry of the wall smile. So first I listened to this patient and her expectations, her needs, and what she wanted to do for her smile. And from a clinical point of view, intraorally, we saw the problem is the mobility of this left central incisor that was splinted, and the presence of such a resorption of hard and soft tissue too around the adjacent teeth. This patient was treated for a previous periodontal problem, treated, and now she was stable. The X-ray show us that this central incisor probably is hopeless, and the dental formula of the other teeth is quite good, and also the probing and the periodontal indexes are stable for the rest of the mouth, except for the left central incisor. And after the first impression, we provided for dental waxes in order to create a pre-visualization of her smile by means mock-up, and give her the chance to pre-visualize her future smile like that, so she can easily know exactly what she can do and which kind of procedure and steps she needs to follow to reach that goal. This is the situation at baseline and after this central incisor extraction, following a rich preservation technique. We will see after, because our goal was to obtain primary stability and hard and soft tissue stability, especially in this so delicate premaxillary area. So we choose for a staged loading by a pre-implant surgery and implant surgery, a provisional restoration time for the soft tissue maturation, and a definitive restoration for a total of 13 months of waiting for the definitive for this kind of patient. And if we need to defend and to support our choices, the literature references are telling us that this could be one of the correct choices we can do for the correct guided bone regeneration technique, the choice of a good implant with a pattern shifting and internal conical connection, the choice of the good prosthesis retention, and the info related to a good ceramic veneer restorations technique. We follow the rules related and present in the literature. So that was the reason why we choose this kind of treatment plan. With the first step, the preservation of the ridge, the suture, and the maturation of the soft tissues like that. by following the concept of a prosthetically driven GBR. So it's not important which kind of horizontal or vertical GBR procedure you do for the restoration of this anterior area. The very important is to do something, because we need to prevent and contrast the obvious resorption in the area of the tooth extraction. So we need to do that in order to create the base to a correct three-dimensional placement of the fixture in order to have a good emergence profile. So we need to use the right implant partner that can allow us, as in this case with the NRH implant, an internal conical connection, very tight and very precise, the chance to have a plateau shifting of the abutment if compared to the diameter of the fixture. We have to select with our dental technician a good S-line contour for the emergence profile support, and after the maturation of the art tissue, the X-ray was like that, ready after 6 months for the implant. And the clinical feature is the stability of the soft tissue, but adhesions on horizontal adhesions of the art tissue is present here and need to be corrected during the implant placement. This is the definitive treatment plan with a veneer in this area, with a veneer in this area, and another all ceramic restoration ear and ear, and the all ceramic crown supported by an implant in the left central incisor area. So the implant placement was done correctly in a three-dimensional orientation by following the rules with a 3.5 millimeters diameter implant. The rules to maintain 1.5 to 3 millimeters horizontally between the implant and the adjacent tooth, a distance between the contact point to the bone crest of 3 to 5 millimeters, and an apical placement of the implant shoulder 2-3 millimeters at least apically if compared to the CAJ line of the adjacent tooth as a reference. After the horizontal GBR was performed, and this is a short video of the surgery related to the flap elevation, the use of standardized steps for the drilling procedures. No guided surgery was provided in this case, because with the flap elevation we saw perfectly which kind of tissue were available, and we knew the perfect orientation we can choose for this kind of fixture. In this case, we plan to not use the guided surgery. Very helpful in other situations, for example, in post-extraction cases, right? Different phases of the drilling, and the correct drilling 3D orientation, very helpful for us, and the gently fixture placement into position 1 to 2 millimeters subcrestally, because of the precision of this connection may allow us to stay safe in this case, right? No peri-implant bone resorption due to a subcrestal position will occur. After the horizontal GBR, very simple, because it's only for cosmetic reason. with a xenographic material and collagen membrane placed with a double layer technique. Very simple and standard procedure. And after the flap passivation, in order to have a good primary stability, the suture could be performed. And this is a situation occlusally and frontally, and the maturation of the tissues with the restoration of the convexity in a buccal area of the left central incisor, and the provisional restoration. We provided first to obtain a screw retained provisional restoration with an impression of the fixture at the surgical re-entry, and while the soft tissue was maturing, we were ready we were ready for the ceramic veneer impression, and we used the template obtained by the dental vexus reference. We were ready for the teeth reduction, guided teeth reduction, and we were ready to put for definitive impression customized pickup provided for the dental technician by considering the same emergence profile of the provisional, and we were ready for the definitive impression after the screwing of the provisional into position, and the patient can go back home waiting for the definitive with a provisional obtained by the use of the mock-up as template for the provisional. And she can start smiling. This is the situation before and after, while she was waiting for the definitive. When they were ready, with the same emergence profile, no correction of the emergence profile, everything was good. Zirconia abutment was selected for this kind of restoration, not gold hue but zirconia in this case, with the not stock but CAD CAM manufacturing system, just following the rules that we can find easily in the literature, telling us that a customized emergence profile shape can support much more better periimplant soft tissues if compared to stock, and the manufacturing data are supporting this kind of choice. So we provided with the dental technician to be sure that an adequate S-line contour can be provided in order to save space for the soft tissue horizontally and vertically. This is the sequence phases of the mock-up and the procedure related to the dental technician phases, and we used obviously titanium-based zirconia abutment with the connection titanium versus titanium of the abutment to the fixture. And these are the all ceramic restoration for the adjacent teeth. This is the situation after the removal of the provisional and the screwing of the abutment into position and the cementation of the all ceramic veneers and crowns. And this is how stable this kind peri-implant and periodontal soft tissue were, the situation before and after, and the patient was happy too. The situation from a radiographic status at baseline with a good representation of the implant orientation from apical to coronal with the 2 millimeter subcrestal positioning of the fixture, and we were very safe because a good internal conical connection of this enriched implant was provided for. And we know that this kind of internal conical connection is the key point to maintain the stability of peri-implant art tissues. And for the stability of the peri-implant soft tissue too, a good pattern shifting was provided by our implant in order to save spaces for the base of the soft tissue around the implant. And if we add another prosthetic concept as the S-line contour, we can have a good space for the soft tissue development. If we do like that instead, a butt joint, old style, flat to flat connection, we lose this kind of space here. We lose height and thickness of the soft tissue, and a recession will occur. It's very easy to understand the difference from the bad red one to the good green one, right? So 1 year and 2 years after, this is the situation, very stable situation, very stable X-ray feature, and the baseline to the last follow-up extraoral photo, and this patient is very happy. I was so happy to help us too. And the secret was a global approach to the smile of this patient, not the treatment only of the central incisor. So we tried to satisfy this patient by respecting the rules of the pink aesthetics, the 3D placement of the implants, and the good GPR procedure performed with a good implant geometry selection, and with a good implant connection system, and the white aesthetic rules with a good platinum shifting for the implant, an S-line contour allowed by our dental technician, a good retention system of the prosthetic components, and a good ceramic manufacturing, right? And so this is the end of my case discussion. I hope to share with you as much knowledge we can and stay together and grow together. Again, thanks to Dr. Park and his fantastic staff. And please don't forget to visit the Megagen homepage for the more discussion for more dentists in imegagen.com. Bye bye. See you.